us. So welcome everyone. I want to thank everyone for joining today. I am going to say that this information presented during this session is not intended to be substituted for professional medical advice. All content is for general educational purposes only. Our guest is not compensated for their participation, nor does the company have
what's happening here?
And if I may ask, I should ask this in the first, if everyone can mute themselves so that the meeting can run smoothly. Thank you. And our guests are not compensated for their participation, nor the company as a whole receive preferential treatment. They are generously sharing of their time and knowledge on this important topic. So I will introduce our expert speakers, and then I'll turn it over to Lauren until Dr. Moghekar joins. So Dr. Abhay Moghekar is on the faculty at Johns Hopkins University and serves as the director of the Adult Hydrocephalus CSF Disorders Program. He is
How come it's not recording
in
for
neurology
me?
and clinical neurophysiology and has over 135 publications, peer-reviewed journals. His research focuses on understanding the biomarkers in the cerebral spinal fluid in hydrocephalus and Alzheimer's disease. Lauren Barbieri is a nurse practitioner with specialty in neurosurgery and neuro-oncology at Thomas Jefferson University Hospital with 20 years of experience. Lauren currently serves as the co-chair of the Brain Tumor Support at Jefferson. She also serves as principal planner for a Brain Tumor Division's annual continuing medical education symposium, as well as the Patient and Family Brain Tumor Symposium. She has spearheaded many education and advocacy efforts, including developing comprehensive patient education a book guide to patients through their various stages of their diagnosis. So I will turn it over to Lauren to get started. Thank you, Lauren, so much for joining us today.
Thank you so much for allowing me to be here with you all. I greatly appreciate it. It's Lakeisha Harris and Amanda Garzon are wonderful to work with, and the Hydrocephalus Association has been doing so many wonderful things. So it's really an honor for me to be here with you guys today and kind of go through some questions that you have regarding possible diagnosis of NPH, hear a little bit of your stories, and I'm happy to share the knowledge that I have with you and answer any questions. I do have a few slides. I could share my screen just to bring up, let's see here. Can everybody see that okay?
Yes, it's coming up.
Can you see that okay?
It's slowly coming up, but it's starting to share. Okay, there we go, Lauren.
Okay. Okay. Sorry, my connection's not the best today, I don't think. Okay, so I know this question and answer is NPH left untreated. So the first slide I wanted to go over with is, am I lagging a little bit? Sorry, Lakeisha, is it?
No, you're good. You're good.
Okay. Okay. So we know that the diagnosis of normal pressure hydrocephalus, most patients have gait dysfunction associated with some incontinence of bladder, as well as some short-term memory issues and dementia. So if you can see here, this triad of symptoms, plus a lot of times when you start to get these symptoms, your primary care provider or neurology will order you a CAT scan, MRI scan, and we look to see if there is hydrocephalus present, if the ventricles are a little bit enlarged. So that as well helps us make the diagnosis for NPH. Down here is a picture of a lumbar puncture, which I'm sure some of you have had during the workup. Over here is a graph. It's pretty small. I can send it out as a separate attachment, but it's the differential diagnosis of NPH. So a lot of diagnoses, as you can see, have gait disturbance, dementia, a lot of them, not just NPH. So when we're working patients up, there's this whole list of variables that if patients don't meet the criteria for NPH, you can certainly be worked up for it for other diseases. Normal pressure hydrocephalus workup, which I kind of just said, the clinical symptoms, short-term memory loss, the classic shuffling gait. Most of the time, the gait you'll notice is patients take these little baby steps, looking like a shuffling gait, as well as incontinence. For the workup, we usually do a lumbar puncture outpatient, which is a high volume tap, versus a lumbar trial, which is usually 72 hours in the hospital. And at that time, we put a lumbar drain in a patient for 48 to 72 hours, have you work with physical therapy, and see if your balance improves. Balance is usually the first thing with NPH that we see that usually improves first out of all of the symptoms, which is important to know. When a shunt is not recommended by neurosurgery, we usually refer patients to our neurology colleagues and our movement disorder team to be worked up for other conditions. We provide prescriptions for physical therapy, occupational therapy to help with your gait. Oftentimes we refer to urology. It could be a bladder issue that patients are experiencing, not necessarily linked to enlarged ventricles. And also neurocognitive eval is always great for memory evaluation and neuropsych workup. So those are just it's just a few slides I wanted to share. I wanted to leave it more open to Q&A with everybody, but I wanted to give a brief background as to what NPH is and how we work the diagnosis up.
Thank you, Lauren. So you mentioned like when it's not recommended, when shunt is not recommended, what makes a person not a candidate for the shunt?
That's a great question. So generally, what I find is the best way to see if somebody needs a shunt is we bring them in. Usually our team, we bring patients in on a Monday. We have them work with our physical therapy team, and we also consult our neurology colleagues and in the movement disorder group. And patients have the lumbar drain placed for around 48 hours. They work pre and post drainage, and we see if the drainage is helpful. If we see that patients are improving, we recommend shunt. If not, we recommend further follow-up with our team that they meet inpatient, the movement disorder team. So a lot of times patients will be worked up for things like Parkinson's disorder, a neurodegenerative disorder. There's other disorders that can kind of present as normal pressure hydrocephalus, but if we see that your balance isn't improving and we see that your gait is not improving after 72 hours at least with drainage, then we're less suspicious of that NPH diagnosis.
Okay. And what if a neurosurgeon or neurologists tell them, oh, we're not going to do anything. You look great, you look fine. We're going to just watch you. What does that mean for short term and long term?
So a lot of times, long term, you will follow up with neurology. Certainly, we always say to patients, let's see what neurology has to offer. If you feel like you're not getting better, if you feel like you're getting worse, let's do a scan again and bring you back and follow up. Sometimes if patients get just a lumbar puncture first, and they don't see any improvement, then we will offer the lumbar drain trial. I always just like to say the lumbar drain trial is like the gold standard. It really can give a better diagnosis than just a one-time LP. But we will bring patients back and we will work them up again, whether it's another lumbar puncture to assess. Certainly, if you haven't had an MRI of the brain, we recommend that you have an MRI of the brain too. Sometimes we can see transependymal flow if that's present. That's consistent with hydrocephalus as well. But a lot of times patients can get scanned, and yes, you do have enlarged ventricles. As your brain ages, there can be some atrophy, which is quite normal. But it does not necessarily mean that it's correlated to NPH. It's just an anatomical finding that we can see.
Okay. And so when it is either they're watching or they're not recommended a shunt, does any other treatment help, like physical therapy? Will that help with gait? Um, does it help to?
Physical,
Mhm.
yeah. Physical therapy, that's always helpful, whether you have NPH. We even patients who have NPH and they have a shunt, we recommend physical therapy. If you have a movement disorder, or physical therapy can always help. There's vestibular therapy, there's balance therapy. We always recommend that for patients with a neurological diagnosis. If you have issues with balance and gait disturbance, that can definitely help you.
How about
Um,
cognitive therapy if they're having some issues with memory?
what's that?
How about cognitive therapy if they're
Oh,
having
yeah. So,
with cognitive decline?
right. So, yeah, we have a great, I always recommend neurocognitive therapy. We do have a team that evaluates patients pre and post shunt placement as well. A lot of times, patients who have short-term memory problems, if they're being worked up for dementia diagnosis, even with NPH, a lot of times the gait is what first improves, and it takes a long time for short-term memory to improve. So we always recommend, if you're having issues with memory, that neurocognitive eval is very important.
Okay. And what if someone has a lumbar or spinal tap lumbar drain and they do see improvements, but they're being told that they will no to getting the shunt because of other reasons? Is there any good reason to say no to a shunt, such as psychiatric reasons?
Yeah.
Any other reasons?
Not generally speaking, I mean, we have patients, if patients show improvement after the lumbar drain, after a lumbar puncture, and their quality of life is improved, I mean, it's very drastic. The patients that I see that require shunts, once they have that lumbar drain, once they have the lumbar puncture, they're like a they say that they're back to their themselves. Their families see it, their caregivers see it. They generally improve and they're able to, go back to their daily living prior to the diagnosis. Um, so unless it was somebody who had like a really severe, surgical risk, like a cardiac, we'd have to get, those things worked up. But if somebody looks like they're going to benefit from a shunt, we generally think that, we that's what we recommend.
Okay. What are some of the symptoms to watch for with the progression or ongoing care for symptoms?
Yeah, so anytime, even if you have a shunt. So I saw somebody put in the chat right now, my neurosurgeon's wonderful team insists on setting 1.5, but can that, so before you get a shunt, there's different settings on the shunt, which, the lower the setting, the more you drain. And nobody ever really knows what the best setting is for a patient until the shunt is placed and until they have it for some time. The lower you go and the more fluid that you drain, a lot of times patients feel that their symptoms improve because you're draining more fluid. Um, so, it's always it's kind of trial and error a lot of times with patients to see what setting works the best for them. But I would say, if you're still having some symptoms, then there might be room for you to decrease the shunt. But again, we have to look at the CAT scan and make sure everything looks well and make sure that, everything on the imaging wise is okay.
Thank you, Lauren. So what, I know this is kind of a hard question. I always get this question every time someone calls in and they're not a candidate for shunt, candidate for a shunt. What are the common symptoms of end stage? I don't know if we can like give a definite definition for end stage NPH. I always say that, we don't have, it's not really defined, but are there any common that you've, in your experience, common symptoms of end stage NPH?
Yeah, it would be basically the gait is just patients are really, it's very hard for them to get up from sitting in a chair to standing. So it takes a lot of effort to go from sitting to standing. They need a lot of assistance when they're walking. Very, very difficult for them to walk, as well as incontinence. Um, in diapers a lot of times. Sometimes we have seen people that have been tried to work up for years and, finally, the patient's families they're caring for them, and they're in diapers and they're incontinent and they're not able to walk. So I would say those are the most severe symptoms that we see. Very cognitively, it looks like dementia. That's pretty much, I would say, like the end stage of NPH.
Okay. Is there any like care that they can get through social services or anything that will help them along as they progress in the condition?
Yeah, definitely. I would say, if it's not treated, you would always want to reach out to like your social work. If you have a social work team, the social worker is usually good about home care, physical therapy,
Mhm.
things like that. That's always helpful to have home care come in and evaluate the patient.
One question on ETV. Does ETV help with balance and equilibrium?
So ETV is not really the preferred treatment for normal pressure hydrocephalus. We do ETVs for something called like aqueductal stenosis, and those type of things is more like an anatomical issue. The VP shunt is usually placed with different settings for patients to be dialed up and down as far as draining fluid. ETV is not a programmable device. That doesn't really that's not going to help usually with the diagnosis for NPH.
Thank you, Laura. And I see in the chat, ETV is endoscopic third ventriculostomy. They were
Correct.
asking what that's
Correct.
what.
Yep.
Um, so, Lauren, and then when someone's not a candidate for shunt surgery or ETV is not an option, are there any other resources or anything that will help them uh, progress well or have a good overall quality of life as they progress?
Right. I would say if somebody's not a candidate for a shunt surgery, we always defer to if you see a neurologist, usually generally a movement disorder neurologist is somebody that you want to see that can be very helpful with your diagnosis, because there's a ton of movement disorders um, that can help. There's medications sometimes that they will trial patients on. But usually those are more or less the diagnosis for the actual movement disorder, because if you really do have a diagnosis of NPH, most patients do pretty well post shunt. Everybody will have probably um, you know a baseline for that diagnosis. But I would say if you're not diagnosed with NPH and you're having symptoms that are progressing, I would see a movement disorder neurologist.
Okay. And then going back to like the initial like diagnosis and testing, like spinal tap, if someone does improve after the spinal tap, but they choose not to have the shunt, are frequent spinal taps or periodic spinal taps okay, recommended? Someone may like they go back every 6 months. Is that
Yeah.
recommended or is it okay?
So we have seen some patients who are nervous about having the shunt placed, which I totally understand. And we have seen some people undergo multiple lumbar punctures. Anytime you undergo multiple lumbar punctures, though, you are putting yourself at the risk just for introducing, uh, like things like meningitis. So, I mean, it's not a permanent solution. It's only temporary. If you truly have NPH, and most of the times, when you get a shunt tap, those symptoms will only improve to like maybe 24, 48 hours max. So that's all basically patients would get for even if they had repeat LPs. It's not going to last long. The effect of the lumbar puncture is not going to last long. So it's not something that we recommend.
Okay. Are there any medications that could help to slow the progression?
There's not that many medications. There's medications for like memory loss, but nothing for like the balance. There's medications for incontinence, But again, it's treating the underlying condition the most appropriate way, and then managing some of those symptoms that are still hanging around to see if you can get them improved. You could try with the medications.
Excellent. Thank you, Lauren. So I would like to open up the floor to questions. Please keep in mind that Lauren is not your treating specialist, so she cannot answer in a medical, answer your questions medically. So keep it general, and she will answer to the best of her ability using her knowledge and experience. So, Linda?
Thank you, Letitia. Because we're on the subjects of lumbar puncture, I just wanted to add, and I get a lot of rejection for this. I've been my NPH, and I've been diagnosed with idiopathic communicating normal pressure hydrocephalus. I've been treated for 5 years with lumbar puncture. The punctures get me so-called normalized. My gait improve, everything improves for between 2 to 4 months. But I know almost nobody uses this kind of treatment. I'm grateful for it. I'm at Penn, University of Pennsylvania. I have my neurologist. I have 2 neurologists, as a matter of fact, one who supervises my lumbar puncture. And I'm just grateful that I rejected the idea of having a shunt after studying for myself the various experiences of people in their late 70s and 80s. I'm 81 years old. So I just wanted to share that and get any opinion of the experts who are here, that it has worked for me for more than 5 years. And I intend to continue treating it with lumbar punctures, fewer. Now I wait longer between, at least 3 months. My last one was November 30th. I'm scheduled for another one in February, mid-February. So anybody who has an experience with lumbar puncture as treatment for NPH?
Yes, I have. Can I talk for a moment? I don't know if I'm muted or not.
No, we can hear you.
You can hear me. I've had 3 lumbar punctures of 30 cc's each time, with not remarkable results afterwards. Although friends have told me that I've improved in my stability and equilibrium, but I frankly wasn't aware that I had improved significantly. But I refused a shunt, and I've been living without a shunt for 4 or 5 years now, and I've had continuous physical therapy here I'm in France. I first tell you that, and I've had continuous physical therapy that's helped me, and I maintain my stability and equilibrium. I haven't fallen down, or I haven't fallen down seriously, and I have my symptoms are not so serious. I'm not really shuffling. I only use a cane to walk. There's security, and I'm still driving.
Me too.
And you too. And I'm okay. And I'm happy that I'm pleased up until now that I haven't taken the shunt, because there are so many apparently negative side effects. But now I've discovered something, and I've discovered ETV, and I've found there's some very, very good reports about success of ETV here in Europe. I don't know about the United States. It seems that you don't do it very much, but the ETV success rate here is extremely high, 95%.
Really?
Yeah, it depends on the selection of the candidates. But choosing candidates, and I'm 82 years old, so I have also the fact of the negative factors of aging, which affects my balance and equilibrium, certainly, and memory, and also incontinence. A bit of incontinence, urinary incontinence, but it's not very serious. And I feel like I'm doing okay without a shunt, frankly.
And thank you, Thomas and Linda, for sharing that. not meaning to cut you off, but thank you for sharing it. And this is definitely a good place to share. Do keep in mind everybody's individual experience is different, and shunts are successful for many people. So I wanted to make sure I say that. Well, thank you for sharing your experience with that. I know Lauren touched a little bit on ETV and why. Well, that is not the best treatment option for Thomas, for individuals with NPH. Do you want to kind of like go over that again, Lauren?
Yeah, I just wanted to say to Thomas and Linda, I'm really happy and excited for you guys. Having a shunt placed is not by any means, I totally respect the fact that you guys are going with lumbar punctures and doing what you know is best for your body. I believe that all patients truly know what's best for them. We can have multiple discussions and offer things, but if that's what's working for you, I totally, support that. And I think that that's a great thing. As far as ETV goes, ETV is something that is placed in the third ventricle in your brain. The VP shunt a lot of times is placed, the tip of the catheter is placed in the lateral ventricle. And there's different, that we find that placing the VP shunt is probably the most beneficial because of where the shunt is placed and the fact that it's programmable. Most patients with NPH benefit from programmable settings rather than just a fixed setting, something like an ETV. Again, we see ETVs, something structural repair for like something like aqueductal stenosis, but our gold standard is usually going to the VP shunt with a programmable valve to help patients. So that's generally the safest things to do for our NPH patients. It's not really putting the ETV in the third ventricle. So that's why we recommend NPH again. I mean, VP shunt for NPH. It's probably the more safer thing to do.
Thank you, Lauren. And Dr. Moghekar, we were just going over a question someone asked or asked about ETVs, if that's recommended for NPH patients, and Lauren was kind of going over that. And there were some others who do repeated lumbar punctures, and they, felt that it's been successful for them.
Yeah, I mean, sometimes, patients don't qualify quite for shunt surgery, but they have a clear subjective improvement from a lumbar puncture. The question is the feasibility of doing it every few weeks or every few months. And over time, that benefit wanes in our experience. So it's reasonable to try it out, but we've not had good long-term success with just repeated lumbar punctures.
Thank you, Dr. Moghekar. Cindy, did you have a question? Nope. Yeah, there you go.
Thank you. I have been diagnosed with idiopathic communicating NPH. I had a lumbar puncture in 2017, and I also had stuttering as part of my symptoms. And many neurologists told me that I was anxious and kept putting me on anxiety medicine, anti-anxiety. But a good doctor at Tufts, neurosurgeon, did a lumbar puncture, and it was as if my whole world had opened up. The cotton filling my head went away, and I could walk, and I didn't pee myself for a day, which was so lovely. And I could put together coherent thoughts. I actually sang a song and danced with my sister. But 48 hours later, I went back down the rabbit hole. But since then, I went to one neurosurgeon who told me to come back when I was in a wheelchair, that I was too young. And now I have I've been to every hospital in Boston, and they keep saying this is all related to your child abuse when you were little, and what you need is a psychiatrist. Stuttering doesn't come with hydrocephalus. So now I have a psychiatrist who has put me on a medication that's making me a zombie. I was falling. I use a walker, all the things. And now I can't even get off the couch. But I'm not stuttering that much. So, hey, there's that. But I wondered, do I give up at this point and just live on the anti-anxiety medicine? Because I've hit everybody in Boston and they all seem, oh no, these are psychosomatic. Even though I have the MRIs and the CTs that show, and I have the symptoms, they just keep telling me it's psychosomatic. And now I'm just drugged. And I don't know what to do. I'm only 69. I can't even take care of myself now. Thank you for listening to me.
Thank you, Cindy, for sharing that. In general, Dr. Moghekar and Lauren probably can speak generally to it, but not necessarily give you direct medical advice. Dr. Moghekar, do you want to address any portion of that? Let me check you to unmute. There you go.
Yeah, that's a tough situation to be in, Cindy. I'm sorry to hear that. Can be very challenging to give specific recommendations at an individual level, but broadly, having the imaging signs of ventriculomegaly, does suggest hydrocephalus. But the more important question is, will a shunt help you? And to answer that, we do these spinal taps, and we do quantitative measures of gait and cognition before and after the spinal tap. And as long as you meet a certain threshold of improvement on those objective tests, generally, shunting is favorable. So again, without knowing the details of what assessments they did in Boston, it'll be difficult to give you any specific recommendations. But to emphasize a point again is that just having big ventricles, doesn't automatically mean that a shunt is going to help you. You need to do further testing to figure out, is a shunt going to help in the future? And that's typically done by mimicking essentially what a shunt does, which is, take out some CSF with a spinal tap, generally 40 to 50 ml, or you can take out more CSF with a lumbar drain in the hospital, where you can drain around 300 to 400 ml of CSF. And that's considered a definitive test, which essentially mimics what a shunt does. And you have to do quantitative tests of gait and cognition before and after to really prove to the surgeon as well as to yourself that, this is a real improvement and it is worth the risk of undergoing shunt surgery to get this level of improvement. So again, sorry to hear about it.
Dr. Moghekar, as a follow-up, I think you bring up some really great tips for patients, but I'm wondering if you can kind of synthesize them for 1 second, because both Cindy and then Lorraine also brought up, what do you do when you feel like you're getting the runaround? And, you mentioned having the testing both before and after. I think, let me take a step back. I think one of the challenges that we see when we're supporting individuals, and that we've learned over time by being so close with so many of you on this call, is that even though there is a triad of symptoms that define NPH, there are other symptoms that can be indicative that something, is going on, complementary to what is also being experienced. And so when people are saying, well, the stuttering's not NPH, or the declining in handwriting's not NPH because it's not gait, it's not urinary incontinence. I think, in your experience, you've seen that there are a number of symptoms that come hand in hand that aren't in the typical triad of the 3 symptoms. So when you feel like you're getting the runaround, what should patients be asking for and communicating with their doctors to help move the ball forward, maybe, or to, I don't want to say convince them to look more holistically at the potential diagnosis possibilities, but I guess that's really what I'm saying. So what kind of questions should they be asking? Should they be asking for, could we do testing, neurocognitive testing, both before and after? Should we be doing a spinal tap? So what's your advice?
Can we have your introduction, please? First time I'm seeing you.
Oh, hi, Linda. I am
Hi.
Amanda Garzon, and I'm the COO of the Hydrocephalus Association.
Hello. I know I've seen you before, but it's been a while.
I think you've probably seen me in the Ask the Expert videos that I did with Dr. Moghekar.
Yes.
And Dr. Luciano. Most people see me there.
Thank you.
Yeah, I think, generally people go and see their primary care physician, and then they get referred to either a neurologist or a neurosurgeon. Not all of them have expertise in NPH. So they may not be aware of the nuances of the assessments of how people are selected for shunt surgery. So a simple thing to ask them would be, would they mind referring you to somebody who's an expert, hopefully someone locally that you could drive to? The best partner would be Hydrocephalus Association themselves. They know who are the experts in different cities and states for NPH, and they're an excellent resource for these subject matter experts. And the Hydrocephalus Association also collaborates with the Adult Hydrocephalus Research Network, which are specialized centers throughout the US and Canada that specialize in NPH and really know how to assess NPH and are well aware of the variants that can present differently than typical NPH does. So I think reaching out to the HA, to get referrals to these experts would be my recommendation.
Thank you,
And
Dr.
if that's not available, just in terms of trying to work with your current team, what do you feel patients should be asking for to help get a better holistic assessment of what's going on?
Yeah, I think NPH can be confused with so many other disorders of aging or other neurodegenerative disorders. So I think having a neurologist on board definitely makes sense. So if you've not been seen by a neurologist or a geriatrician, it would make sense to see them also, because there are many mimics for NPH.
And then
I would say,
are there diagnostic tests that both of you feel are musts for a full NPH workup? Because I feel like a lot of patients don't get a full NPH workup necessarily, particularly when they're at a place that does not have an expertise in the condition.
Go ahead, Lauren, you were about to say something.
Oh, no, I was just agreeing with Dr. Moghekar, saying that, there are a lot of other disorders, neurodegenerative disorders, neurocognitive issues, that can present as part of the workup for NPH. But, gait, I think, is a big factor with these patients with actual NPH diagnosis. So you can have other symptoms like stuttering or hands, or there's other minute things that go along with the diagnosis, which we work up. But a lot of times, from our experience too, sometimes patients don't always have that incontinence, but their balance is really bad or their short-term memory is bad. They list the triad of symptoms together, but sometimes patients will have, maybe 2 of those symptoms more present. But I would say, we definitely recommend an MRI of the brain for workup if they haven't had it, CAT scan, lumbar puncture, lumbar drain trial. So things like that. Dr. Moghekar, do you have any other?
Yeah, so 2 of the biggest mimics of NPH are Parkinsonian disorders. Parkinson's disease is the commonest kind, but there are other kinds like PSP, MSA, and CBD that can also mimic NPH. And often the symptoms are very similar to those of NPH. And sometimes seeing a movement disorder specialist can help in diagnosing these conditions. There are special scans called as DAT scans that can help with the diagnosis of these conditions. And the other great mimic is Alzheimer's disease. Even though we don't consider Alzheimer's disease as affecting gait, there are clear motor manifestations in Alzheimer's disease with slowing of gait that starts, years before memory declines. So Alzheimer's disease can mimic NPH. The ventricles are big even in Alzheimer's disease. And now there are specialized tests in CSF as well as blood to make the disease diagnosis easier. So in fact, routinely when we do spinal taps for our patients for NPH, we now measure these proteins. These are biomarkers of Alzheimer's disease in CSF. And that gives us an idea, does this patient with NPH truly have NPH? Do they have underlying Alzheimer's disease? And not uncommonly both. So having these objective measures of proteins in spinal fluid is helpful and is available at specialized centers. I know it's still not out there in the community though.
Thank you, Dr. Moghekar. And I think I run into this issue all the time. Like people are very in a rural area or far out, and they only have one neurologist that may not be experienced in, the diagnosis of NPH, and they're not working them up very well. How do they request? Can they say like, I want a lumbar puncture or spinal tap, especially if they're saying no, we won't give it? How do they request that?
If somebody is not used to doing the pre and post assessment, it can be challenging because yes, they'll do the lumbar puncture, but the more important thing is, will they do the gait assessment correctly? And maybe if they're not trained in doing it, they can ask a physical therapist to do the assessment before and after. So as long as they have somebody with some expertise in doing gait testing before and after the lumbar puncture, then it's reasonable to request a lumbar puncture, but with some objective testing of gait. It can be a very simple test. The timed up and go test is a very well validated test. It's used in many centers. It takes less than 2 minutes to do it. So just having somebody do a simple quantitative test of gait before and after the LP may be enough.
That's very good. Thank you. We are almost we're 10 minutes out. Are there any other questions that anyone would like to ask of Dr. Moghekar and Lauren?
Yes, I would just like to ask if they've heard of the trial that's being done at Yale for a new kind of shunt. Have you read about that? I've been following it.
I'm not sure. I've followed that.
Well, they've been doing it for a couple of years. They expect to be completed in next year in 2025. It's a new shunt that requires no brain surgery. I'm anxious to get what the results, the statistics of this 4 year trial is. The new shunt would go in the neck, in the vein. So they consider it an advance in that they would not have to do brain surgery, which is what convinced me not to get a shunt.
All right. So now I know what you're talking about. So it's a diverts CSF directly into the venous system of the brain.
Correct. Yes.
Yeah. I mean, I'm all for advances in shunt surgery. I think it's good that they're doing the trial, and we all look forward to those results.
So Linda, just to keep expectations in check, the trial is the first step. They still, as part of the FDA approval process. So there's still, a number of other hurdles, I'll say, that the company has to get through before the product can become commercially available.
But it's exciting because it's the first time a new
Very
approach
exciting.
has been looked at. And that's why I bring it up, that because we certainly do need new approaches to this.
It's not the first, and it's not the only new approach. There are a number of other shunts that are different than the current ways that shunts are done now, that are being researched and studied, that are in animal trials, both here and in Europe. but Ceravasc is certainly a really exciting company. And, we've been talking to them since they first, came out with their idea years and years ago. So we've been really excited to see how they've progressed through the process. I always am worried. I always want to keep everybody's expectations in line, because it can take a while to get to commercial availability.
Yes, but I think the more people who persist and insist, that there would be more doctors who know what NPH is. I'm very lucky to be here. We're University of Pennsylvania, and to get the neurologist that I have, because the first neurosurgeon I saw said I had to get a shot immediately. I said, oh no. And to be self-aware, looking up, finding information for yourself allows you to ask the right questions.
Absolutely. We'll definitely come to our research update webinars, because we are always happy to be able to share all the latest that's happening.
When are you doing that? I haven't seen.
We always email out. I'm not,
Okay.
Dr. Chow is on right now, who's our research director, but I don't want to take time with us trying to find our schedule for webinars. Just make sure you look for our emails and go to our
look for
website
it. Okay.
for upcoming webinars. And of course, we have our conference this summer in Tampa, Florida, which will have a very strong NPH track, because we will be in Florida, and we're working
I might come to
with
that in
adult
Tampa.
providers
Okay.
down there. So Lakeisha will put the conference website in the chat. That's July 25th through 27th in Tampa, Florida.
Yes. And Cindy, before I move on to you, Lauren, I saw you unmuted. Were you going to say something?
I was going to say something that was kind of off topic, but similar to what Linda had brought up. Just for patients, there's a diagnosis of, like, for instance, pseudotuberous cerebri. That's a patient population that we used to refer for shunt placement. But now we refer, to them for venous stent placement. This is something different than NPH, but just looking at different ways of treating increased elevated pressure within your brain. Instead of doing the shunt, we're now seeing that placing, venous sinus stenting, getting to the root of the issue, is a new way to go, rather than recommending a shunt. So it's kind of off topic, but it was similar to what Linda was saying.
Thank you, Lauren. Cindy?
I just wondered, would diuretics help with the pressure and the massive headaches, feeling like your head's just gonna go boom with all this fluid? Would a diuretic help reduce the discomfort by reducing fluid, or am I being silly?
No, I mean, there's a diuretic called as acetazolamide, also known as Diamox, that has been tried in patients with NPH. There have been 3 trials conducted on it so far. There have been modest benefits by taking that medication. The problem always has been long-term safety, and people are not able to tolerate that medication for a long time, because it causes a lot of metabolic disturbances in your body. So while it can work, definitely it has been shown to work. The problem is, long-term use and the safety and efficacy of using it in the long term.
Thank you. Lorraine? You have to unmute yourself.
Okay, gotta find it. So this is my mom. We're talking about my mom, and in the chat, I was talking about, we are just round and round and round, shortage of neurologists. Is there some place that we can go to? I sent a message to Mayo Clinic. I'm waiting for a call back. But is there some place? I mean, we've had the pre-testing with physical therapy, then the lumbar puncture, and then afterward, it was just absolutely amazing, the difference between it was like my mom was back. The walking, I took a video of the walking. It was huge. Her cognitive skills was amazing. And now, so that was 2 weeks ago. It took us 10 months to get into a memory clinic to get somebody to listen to, this is not normal for my mom. And we just need the shunt done. And is there somewhere we can go that will just listen and just, let's go get it done? How do we have to wait another 10 months of a potential fall with more potential head injuries every other a month or so? I mean, she's got some, well, last week she had a big thing on the back of her head from falling. On the front, I mean, she's so depressed because she knows where she was, where she is, and it sucks. And I'm in the medical field, and I thought I knew how to navigate this, and I'm not doing a very good job.
If you email me, I can certainly search. What state are you in?
Washington. She's
Okay.
in Idaho, which we're right on the border.
Oh,
So
okay.
I'm literally toggling back and forth, playing both sides, and it's not working. And again, I should know. I'm playing cards, games, and nothing's happening.
Okay. If you
And it's
email me,
simple.
I can certainly send you email you some specialists that you
Thank
can
you.
reach out to. Okay.
Thank you.
Lorraine, check the chat.
Okay.
Both Lakeisha and I messaged you in chat.
Thank you very much.
You're welcome. Well, thank you so much for your questions and helping this meeting run very smoothly. Thank you, Dr. Moghekar and Lauren, for sharing your time and expertise with us. We really appreciate it. We learned a lot. So at this time, we are going to conclude our meeting. Again, everyone have a great day and thank you. Bye, everyone.
Bye, everyone.
Bye.